Thank you very much. Good morning. So the dislocated shoulder. By rule, I need to report any disclosures. I do not have any disclosures to report. So the clinical question, what are the best evidence-based strategies to reduce an acutely dislocated shoulder? Brief review, shoulder dislocations. The vast majority are anterior. Over 95% of all shoulder dislocations are an anterior dislocation, much less common to have a posterior dislocation. However, about 50% of these are missed on initial evaluation. Inferior dislocations, also called luxatio erecti, where the patient comes in with the shoulder arm up over their head. This is an extremely rare injury. However, if it occurs, one has to be very careful to evaluate the neurovascular status, as there is a high rate of neurovascular injury. The shoulder evaluation, of course, includes a history. It is important to know if this is a primary first-time dislocation or if it is recurrent. Is it chronic? How long has the shoulder been out? A couple minutes? A couple hours? A week? Sometimes we find patients in the hospital, the shoulder's been out for over a week, maybe even a month. Physical exam, very important for you to be able to recognize a shoulder dislocation. And which direction is it? Is it anterior? Is it posterior? Most commonly, again, by far, it'll be an anterior dislocation, but it's important to recognize this. As you can see, is my pointer working? You can see.
Control and then hit the mouse.
Thank you. On the picture on the right, here is an anterior shoulder dislocation. You see a prominent acromion. You lose some of the contour of the deltoid, and the shoulder is held in a slightly drooped and abducted position. The neurovascular exam, of course, is very important. A radiographic workup is typically what we do in the hospital setting. However, in the athletic training setting, you will not have an x-ray, so you do need to be able to evaluate this, determine that this is an anterior dislocation, and then without an x-ray, proceed with attempted reduction. The x-ray is typically to rule out, of course, anterior versus posterior dislocation and make your diagnosis, but also to rule out a fracture. This would be much more common in the elderly population, but also in the young population, the growing child, 12 or less than 10 perhaps. Those patients do have the potential for a physeal fracture, and one would want to understand that before attempting a reduction. So again, what does a shoulder dislocation look like? This Australian javelin thrower dislocated her shoulder, and as you can see, she has this prominent acromion. Her deltoid is in some spasm here, but she's lost the normal contour that you see on the other deltoid, and she does hold it in an abducted position. In the hospital, she's a little more calm, less spasm, but again, prominent acromion, loss of the normal deltoid contour, and here on the right you see the anterior shoulder dislocation, typical x-ray, no fracture. On the left you see an anterior shoulder dislocation. There is a small greater tuberosity fracture, Hill-Sachs fracture. That's small, that's not of consequence in terms of performing your reduction. This is a common finding. This is not one that would limit your ability to reduce this dislocation. On the right, you see a posterior shoulder dislocation. You can see why someone might miss this on initial evaluation. As first glance, this may look like this is a normal shoulder. However, it is not. The radiograph on the right is a normal AP view of the shoulder, and this x-ray on the left is a posterior shoulder dislocation, which, if you obtained an axillary view, which you always should, you would see that the shoulder is posteriorly dislocated, actually perched on the glenoid. We call this a light bulb sign. It looks like a light bulb, and if you see this, you need to be aware that this is a posterior shoulder dislocation. So reduction maneuvers. There are many maneuvers, and you do not need to know all of these, but you should become familiar with a couple of them Be comfortable with them and have these in your back pocket so you can utilize one or two when you run into a patient with a dislocated shoulder. The Hippocratic technique is more of a historical reference. We don't tend to use this much anymore, as this may contribute to neurovascular injury with significant foot countertraction in the axilla with distal arm traction, but you may hear of this one. Traction countertraction is more commonly utilized, certainly in the emergency room setting. This is where you have two healthcare providers. You have the trainer or physician perform the traction maneuver in an axial direction, a sheet around the forearm, and you have the assistant giving countertraction around the torso. The Simpson technique is with the patient in the prone position. The arm is dangled over the examining table, and a weight can be placed in the hand, or just the weight of the arm can allow the shoulder to reduce with ample relaxation. This is something that a patient can try if they are alone. They can do this over a picnic table or a park bench and relax and try and allow their shoulder to slide back in. Medial scapular manipulation can be added, and I will get to that in a little while. The Coker technique is a more commonly utilized technique. This does involve the patient where they are actively involved. I believe this might help, as the patient may be more prone to relaxing if they are actively involved with the process. What we do is we have the shoulder the elbow flexed to 90 degrees, and the patient adducts their shoulder and then actively externally rotates it, and then the trainer passively forwardly flexes it and internally rotates it, as you'll see here in this video. She is actively adducting and externally rotating, and the trainer is flexing forward and reducing the shoulder. That's the Coker maneuver. The Milch technique, another commonly utilized technique. Patients supine, they can be seated. In this particular technique, the trainer manipulates the humeral head back into the joint. They passively abduct, pull traction, and manipulate the humeral head with some external rotation. So passive abduction, manipulating the humeral head, external rotation till the shoulder clanks in. The Feres technique. Not everyone is quite as familiar with this technique, but it is well described in the literature. This abbreviation is for fast, reliable, and safe. Patient supine. The arm is brought into abduction, and gentle, rapid, oscillating moments are performed around the arm, which is placed into gentle traction. And at the end, there is gentle external rotation. Here you'll see these gentle oscillating movements while abduction is occurring. And you bring it all the way up, above 90, up towards 120, and then you externally rotate right at the end. It's called the Feres technique. Ichimpati technique. This perhaps is the easiest one. Maybe put this one in your back pocket, as it's quite simple. The patient is supine, elbow is flexed to 90 degrees, the shoulder's forward flexed just 20 degrees, and then it's passively externally rotated all the way to 90. External rotation, and that's it. Quite simple. Spacer technique, another very simple one, is longitudinal traction on the arm with the patient supine. You're not trying to lift the patient up off the bed. Longitudinal traction, perhaps some slight external rotation at the end. This one can take a few minutes to allow the shoulder to slide back in. Finally, scapular manipulation. This is with the patient prone. Having the patient prone may help relax them. And then what you're doing here is if the humeral head is dislocated medially, most of our techniques pull the shoulder back out into the joint. But what you can also do is move the scapula medially. That is medial scapular manipulation with the patient in the prone position. You can do this with the Stimson technique, where you have the patient holding a weight while they are in the prone position. So many techniques, many of them work, but what is the evidence? There are several good level 1 studies out there, including this one from 2009. It's a prospective randomized controlled trial, a good number of patients, 154 patients. They compare traction, counter-traction versus the Coker versus the Feres technique. Very interesting, in most of these studies, no anesthesia is given, no medications, no injections. And they had very good results. The Feres technique was the winner, 89% reduction success compared to traction, counter-traction, compared to the Coker, which is only 16%. In addition, the Feres was found to be better in terms of pain as reported by the patients. It was faster as well. None of these had any complications. Another study, 2012, out of the Journal of Shoulder and Elbow Surgery, level 1 prospective randomized controlled trial. Compared the Milch versus the Stimson technique, no sedation. The results, the Milch was much more successful on the first reduction attempt compared to the Stimson, and patients complained that the Stimson technique, it took a while, it was inconvenient for them to be in this prone position for a period of time. Some of them gave up. Excuse me. Another level 1 study from 2012 compared the Feres versus the Ichimpati technique. Again, no anesthesia. Both were very successful. The Feres was 95% successful on the first or second attempt, and the Ichimpati was 91% on the first or second attempt. This is important to know because don't just give it one try. Don't be afraid. Give it a second try if you don't get it in on the first try. The Feres was found to be faster, less painful, and with fewer attempts. One little side note to this study I found interesting. This was out of India, and maybe the patients have to travel a long distance or there's a long waiting line at the hospital, but patients had to wait 3 hours from the time of injury to be admitted to the hospital. Once they were admitted, the reduction was quite quick, 9 minutes from admission to reduction. A more recent study, also a level 1 prospective randomized controlled trial, comparing the Spazo technique versus the Coker maneuver. No anesthesia given. Results showed that the Spazo technique was nearly 90% successful compared to the Coker, which was 70% successful. Finally, a systematic review and a meta-analysis was performed just a couple of years ago comparing all of the techniques we described. And they found that scapular manipulation is the most successful and the fastest technique with the least amount of pain. The Feres technique was considered a good alternative based on their data. Here you see from this same article, the majority of these techniques are successful, at least 80% for the vast majority, the Coker, the Spazo, this would be the Ichimpati. All of these have at least 80%. Stimson, on the other hand, Stimson alone, without manipulation, was not successful. However, pick one or two and have that be your go-to maneuver and be comfortable with it. So I mentioned sedation and medications. Here's a study comparing IV sedation versus intra-articular injections. In the hospital setting, this is typically what we do, but again, as a trainer on the field or in an austere environment, you won't have these available, and as the other studies showed, you don't need these. However, if you are going to utilize medications, this study showed that IV sedation is no better than intra-articular injection, and it is more expensive and takes more time. So intra-articular injection is better than IV sedation. So you reduce that shoulder, now what do? Do you put them in a sling? Yes, of course we do. It's the humane thing to do. It's good for comfort. However, does a sling prevent recurrence? This was studied in the early 2000s, especially by the Japanese. They described an external rotation brace that a patient would wear for a month or so to help prevent a recurrent dislocation down the road. They showed good results, but since then, those results have not been reproduced. So in general, we do not recommend an external rotation brace, and we just place a patient in a sling for comfort after a dislocated shoulder. I briefly wanted to touch on posterior shoulder dislocations. Just the reduction technique is different anterior dislocation. Typically, you want to bring an arm into passive forward flexion and adduction and internal rotation across the chest, and then you do your cross-body traction. You can manually manipulate the shoulder, the humeral head, from posterior to anterior during this process. In this scenario, typically we do recommend IV sedation, and this is typically done in the hospital. Finally, luxatio erecti, that's the one I described. That's an inferior dislocation. The patient comes in with the shoulder, the arm up over the head, considered a high energy mechanism. And again, I'll remind you, this was one that has a high rate of neurovascular injury. If you see someone with this, you must evaluate them very carefully and watch them for neurological injury and vascular injury. However, if someone has this, again, you're in an austere environment, you don't want to leave someone with their arm up over their head, what can you do? There's two techniques. You can do traction, counter-traction, but the orientation of this traction is the opposite of what it would be for an anterior dislocation, meaning, as you see in this picture on the right, the arm is being pulled more superiorly and abducted away from the patient's head compared to, and the countertraction is around the top of their torso, pulling in the opposite direction than it would have been for the typical traction countertraction. Alternatively, a two-step technique can be utilized where the humeral head is carefully manipulated around the glenoid to convert the inferior dislocation to an anterior dislocation. You can manipulate that, and then from there, now you have an anterior dislocation, and you can utilize whatever technique you're comfortable with to reduce the anterior dislocation. So in summary, shoulder dislocation reductions, there are many different reduction techniques. It's unclear which is most successful. Many of them are successful, but the Feres, the Ichimpati, and the Spazo have the highest documented success rates, and I encourage you to get comfortable with one or two of these and have that be your go-to technique. It's okay to not utilize any anesthesia, as you can have very high success rates without it. So this patient does not necessarily have to go to the emergency room right away with a dislocated shoulder. They can be reduced on the field, and it is important to have this as part of your plan of care with your supervising physician. Are you permitted to reduce the dislocation on the field? And I think I can speak for all my partners that, yes, we want trainers and physician's assistants to give it a try. If there's a displaced fracture, it makes sense to us for you to pull traction and realign it and splint it. If there's a dislocated joint, it's best to give a non-traumatic reduction technique. If you are to use anesthesia in the hospital setting, intra-articular injections are equivalent to IV, and afterwards a regular sling is enough for comfort.